So, dear Chair and dear colleagues, my name is Elias-Leon Nolden, and my PhD thesis is about the implication of personalized medicine in maxillofacial surgery. I'm a dentist as well as a medical student, and I'm from the Department of Oromaxillofacial Surgery and Oral Biology. My supervisors are Mihai Vasilko and Laszlo Köles. My SMS is Alex, and my statistician is Silvia Kirstaller. My vision is to transform maxillofacial care with tailored solutions, and my mission is to provide better clinical decisions based on research. I have two ongoing specific goals. In my first specific goal, I'm comparing patient-specific implants and the stock system in patients with TMJ reconstructions, and I'm using here a systematic review meta-analysis to achieve this goal. And let me please tell you why also you might be affected by TMJ replacement. One of the most common reasons or indications for replacement is a long-standing TMJ disorder, and we know that almost 30% of all adults and 11% of all children are affected by it. And untreated, it will lead to failure of the joint, which will increase pain, give problems with diet, mastications, and also then social interaction will suffer under it. And we already know that in just 6 years, the necessary amount of operations will increase by 60%, which will be just 900 replacement surgeries per year in the USA. So what can we do? We have two treatment options. There's a new kit in town, which is the fully customized PSI system, which gives us a unique implant for our patients, unique anatomy. And on the other hand, there's the traditional system, the stock system, which comes in 3 different sizes. However, this stock system often shows decreased or limitations in jaw mobility, and as stated in the current guideline, we cannot draw any stable conclusions due to the lack of global cases. And our aim is now to investigate if the custom or pre-manufactured implant lead to better patient results. That's why our question is which one of the two systems result in better function. In this function, we will measure with the maximal mouth opening in millimeters, as well as the pain and diet measured by the visual analog scale. And our hypothesis is that the PSI is superior than the stock system. We did our systematic search, and we were left with 32 one-arm and 10 two-arm articles. And let me introduce my first outcome. It is the maximal mouth opening. It is, of course, crucial that our patients can keep a necessary opening in order to keep a good oral hygiene and have no interactions or no problems with diet, speech, and so on. We measured this outcome by the interincisional distance in millimeter, and as stated, after surgery, we can consider a success between 30 and 40 millimeter mouth opening. And for this outcome, we could include 40 different studies with over 2,000 different patient data. And here you see our summary plots of change from preoperative in millimeters. We pulled together the 1- and 2-arm articles here. And on the left side of this table, you see the results of this change from preoperative to postoperative, while on the right side, you see now the mean difference between the two systems. And what we found out is that in almost all follow-up time, the custom system is superior than the stock system. There's one outliner between the 2- and 4-year. This can be only explained due to the high heterogeneity of our patient data, and also none of these analyses could reach a mathematical significance yet. Also, this figure illustrates perfectly that you can expect the biggest change, especially directly after operation with the custom system, and also even after that you will have a superior mouth opening up to 2 years with this system than with the stock system. Nevertheless, it also shows that both systems works very well. We decided to analyze separately the 2-arm articles to minimize potential heterogeneity. And here you see also in a very short follow-up time, up to 3 months, that the PSI is still superior than the stock system, as well up to a follow-up time to 12 months, where you can reach a 5 millimeter larger mouth opening with the PSI. If we look at the very long follow-up time, over 12 months, you can already expect a 6 millimeter larger mouth opening, which could also reach a mathematical significance. We also question ourselves, how does sex defined by birth will influence the mouth opening? And if you are male, you can expect to have a 5 millimeter larger mouth opening choosing custom than choosing stock. Also, as female, you can also expect to get a larger mouth opening. However, this change is not clinically relevant. So we asked ourselves, why is there a difference? And we found out that the population, the female group, from these 9 articles, were older and already had a larger preoperative mouth opening. So we also looked what happens if you are 10 years older at start of the operation. You can expect to get a 1 millimeter less increase of opening. after surgery. The same is for the, if you already come with a higher mouth opening, with a preoperative mouth opening more than 10 millimeter, let's say, you will also can get almost a decrease of 4 millimeters. Our second outcome was pain. Pain in the orofacial area, of course, will influence our patient's quality of life horribly, and it is measured by the visual analog scale as well. Also here, the goal is to have a complete minimum pain-free reduction after surgery. And for this outcome, we could include 34 different studies with also over 2,000 different patient data. Here you again see the summary plots of the change from pre to post-operative on the visual analog scale. On the left side of the table, you see the results, while on the right side here, you see again the mean difference between the two systems. Here we have very contradicting results, first favoring stock, then custom, then stock again. This also can only be explained due to the high heterogeneity, as well as this outcome is measured subjectively. This figure also illustrates perfectly that both systems reduce the pain. However, here also it looks that the custom will decrease the pain more in our patients. Our last outcome, the diet, is of course indirectly related to pain and mouth opening. However, it can be assessed differently also with the visual analog scale. Also here we want to have no restriction after surgery for our patients. And here we can only include 17 different articles. And this we decided to subgroup them in a short and a long follow-up time. Here we also have mixed results, first favoring the custom up to 2 years, then favoring the stock system. Again, this is only due to the high heterogeneity of our patient data, and as well as this outcome is also measured subjectively. That's why our conclusion is that both implants work. However, with PSI, mouth opening can be more improved than with stock system. Regarding pain and diet, outcomes were mixed, favoring pain statistically with a follow-up time up to 2 years, while for diet, the stock seems to be better after 2 years. That's why our implication for practice will be that customized should be for those patients who have restricted jaw movements, and the stock system seems to be the good, cost-effective alternative for addressing pain, and both implants address dietary needs effectively. Our implication for research is that research should focus on developing and comparing PSI and address these limitations such as pain and to improve functionality in patients. Our biggest strength is definitely that we have very up-to-date analysis with very narrow follow-up times to see potential difference between the two systems. However, as I said, the big limitation is that there is a high heterogeneity due to no pathology grading in the populations, and that 2 of the outcomes can only be assessed subjectively. We sent our article to internal review, and our target journal is the Journal of Dentistry. Our second specific goal is to compare patient-specific and hand-curved implants in patients with cranioplasty. And cranioplasty protects our patients and protects the brain and increases the brain blood flow, as well as improves the brain metabolism. That's why it's considered as a standard procedure in maxillo and neurosurgery. However, it comes with the highest complication rate of all neurosurgeries, compared 20 to 50 to 2 to 5%. And also here we have the possibility to customize the implant or to hand curve it in the OR. And as you can see already on the picture on the right side, the hand curved implant also shows very low aesthetic satisfactory. That's why our aim is to investigate which of the both custom or pre-curve lead to better patient results. Our clinical questions will be then which of the both have a better clinical performance and long-term success, and this clinical performance is measured by the safety, by the prevalence of postoperative complications, as well as the aesthetic score, and also how fast and how long the patients needed to stay in the hospital. And our hypothesis is here that the PSI is superior than the hand-curved implants. Our clinical implication will be then that they have long-term implant survival, less secondary operations, and also a decreasing anesthesia exposure. We conducted our systematic search, and we will now soon continue with the duplication removal. So to summarize, both of my articles are investigating in personalized medicine in maxillofacial surgery, and I would like to thank for your attention with my favorite quote from Eugen Roth: "A human often feels quite transformed when treated humanly and warmly adored." Thank you very much.
Congratulations on your presentation. Thank you. I would like to ask regarding your second project. I could see there is high complication rate for a cranioplasty. Could you explain what could be the reason for that?
Thank you for the question. We see very different approaches in cranioplasty, such as there are different materials to reconstruct missing parts, such as artificial materials, titanium, PEEK, PMMA. Also, back in the old days, they like to use bone grafts, so autografts. And besides the material, also, as I said, what will focus my second study is that there are difference in pre-curved and fully customized implants, and also the time of the surgery after they perform the, so the most common indication for cranioplasty is decompressive cranioectomy. And the time frame between this first operation, the cranioectomy, and then the reconstruction is also very differ between a lot of studies. So we want to see if we can give maybe more clear guidance, focusing first on if it's a custom and hand curved, but then also if maybe to answer the other 2 points.
Thank you.
Thank you.
Congrats. I have a question regarding your first project. You have mentioned something like that pathology grading is influenced by the heterogeneity. Could you please explain it in a little bit more in detail?
Yes, thank you. So I said that is my biggest limitation is this heterogeneity, and this is due to the pathology grading. So this means that all of these end-stage joint diseases show different severity and different surgical indications in our papers. There are some scores which try to address this, and but these kind of scores are not used in all of the papers. So, and also on the other hand, surgeons like to tend to use like more advanced technology or like the whatever is like say new on the market. And that's why there's a kind of a difference between the indications of these surgeries sometimes, which we try to address with subgrouping or like only analyzing the 2-arm articles separately from the 2- and 1-arm articles.
Thank you so much.
I just wonder that you presented very nice regression curves, and then you always, it was always followed by a forest plot. But if you have a regression curves, you can make, I presume you made with the statistical multivariate linear regression analysis, when you can put all of this cofactor, like for example, what was the opening before the surgery, what is the gender, was biological sex, and so on, which you listed, and there was kind of question that there is not enough data to support this result, but you can put all of this together, and you have a nice, I think it was red and green line, which was the regression line, and then you can calculate it, the intercept and the slope differences between them, regardless of, so you don't have to make subgroup by time, because the regression analysis is more powerful, because you can, it's a continuous scale, so you can input everything together and all of the cofactor, and then you have just one nice table saying that the time, the cofactor like opening before the surgery and so on, sex and so on, you can put together. And then you never showed any statistics on the regression line, which is, I think it's much more powerful than the forest plot. So I don't know, just discuss with the statisticians that why don't they give you some value for that.
Thank you for the comment. We discussed it with the statisticians, or we were talking about it, and I think we had problems with proceeding with this kind of way. But as we are now finished, we can also then go back and take a look again if it's possible, because it's a very good idea.
And if, okay, it's time passed, just one thing which is very, you said at the very beginning that 33% of the prevalence of TMJ, but usually you are talking about those patients, I think because it's a high number, which has some chronic problem like due to the occlusion, orthodontic treatment or something like that, but usually they doesn't have, or they won't have any surgery later on, because otherwise it would be a huge number.
Yeah.
So I'm not sure that mostly the surgery, I think it's coming from the luxation, which was not fixed or something like that. Or do you think that's, how much is the 30%, how much percentage of the 30% will end up with a surgery?
Well, this 30%, like this epidemiology I wanted to give you, was just related to TMJ disorder in general. And of course, you need a very severe form of TMJ disorder and a long-standing and untreated form, or failed treated maybe, to develop such an end-stage joint disease that you need a replacement. You're totally right. It doesn't mean that 30% of the whole population will get a TMJ replacement. However, we saw, like, for example, from the study from UVO, it was a questionnaire from 26, that they expect these numbers to very increase much, which will be once due to the overall age of the population, as well as that they will be more and more, such as, for example, now with the PSI, convenient ways to replace the TMJ, which will make it then also the, let's say, the threshold of when we want to give a patient a new implant. Will put it much more down, because it might be better than to actually replace the whole joint than trying a lot of years with conservative, with arthroscopy, which is nowadays always first choice than doing the replacement. That's always the last options we have. But when we come to a point where, for example, due to new technologies, we can make it so convenient for the patients, then we will also see much more TMJ replacements. Also, the diagnostic possibilities to diagnostic such TMJ disorder or everything which will lead to such a problem will become more and more better in the future. So, yeah, I think that's what I wanted to say.
Thank you very much. It's very interesting. Thank you.
Thank you.